Hello, I'm Dr. Christina Nemeth, and I'm currently serving as one of the fourth year chiefs in the internal medicine program at Broward Health North. For my MPH practicum, I chose to work at Cora E. Branyan Family Health Center, which is part of the Broward Health System, located in Fort Lauderdale, Florida. This was a very meaningful site for me personally, since I actually trained there as a resident, so I already knew some of the providers, the workflows, and most importantly, the patient population very well. That background gave me a unique lens. I could see firsthand what the clinic does well and where there were areas that could be improved. I knew from experience that the patients we serve face a lot of structural barriers. Many are uninsured or underinsured, and there are significant challenges with language, transportation, and health literacy. So I wanted my practicum to focus on something that was realistic, low cost, and most importantly, something that could make a tangible difference in their care. I decided to focus on lung cancer screening, specifically using low-dose CT scans for patients who meet the USPSTF eligibility criteria. The reason I chose this topic was because I noticed that even though national guidelines exist, we weren't consistently identifying eligible patients, and the screening conversations weren't happening as often as they should. In a population that's already at higher risk due to smoking and delayed care, this felt like a missed opportunity that could have real consequences. One of the biggest challenges I ran into, and this won't be a surprise to anyone who's worked in a safety net clinic, was the data. A lot of the key information needed to determine screening eligibility, like smoking pack years and quit dates, was missing or buried in free text fields, so it wasn't as simple as running a report. I had to use a mixed approach. I started with EMR queries using Epic Slicer Dicer tool to generate a list, but then went through the charts manually to confirm which patients were truly eligible. It was tedious but necessary, and it taught me how important data quality and informatics skills are in public health. Another challenge was just the reality of clinic life. Staff and providers are busy, everyone's stretched thin, so I knew I wanted this intervention to actually work. It had to be seamlessly integrated into the existing workflow. I couldn't just hand people an additional task. So I created a simple one-page provider checklist based on the USPSTF guidelines to help quickly identify eligibility. I also made multilingual patient brochures in English, Spanish, and Haitian Creole, written at the level of a fifth grader, and decide with visuals to make the content more approachable. I work closely with medical assistants and nurses so they could help identify eligible patients at intake and offer the brochures before the provider even walked into the room. This way, the conversation was already primed. This experience taught me so much, not just about lung cancer screening, but about how to make public health work at the clinic level. You can design the best intervention in the world, but if it doesn't fit into the rhythm of the clinic workflow, it won't stick. It also made me reflect on the importance of cultural humility, especially when working with immigrant communities who have different beliefs, fears, or prior experiences within the healthcare system. You can't just throw statistics at people and expect them to act. You have to meet them where they are, speak their language, literally and figuratively, and build trust. This practicum reinforced what I've always known I wanted to do, which is to stay clinically active as a physician, but also work at the systems level to make care better, especially in underserved communities. I want to be the kind of doctor who doesn't just treat the patient in front of me, but also works behind the scenes to fix the systems they're navigating. I came into this project with a lot of experience already, both clinically and as chief resident, but this was one of the first times I was fully in charge of designing, implementing, and evaluating a public health intervention from start to finish. And I realized that I very much enjoyed the process, identifying a problem, creating a solution, testing it out, and using data to improve it. It's made me excited to keep building those skills, especially in clinical informatics and implementation science. I want to keep learning how to make the bridge between public health and patient care even stronger. Overall, I'm really proud of this project. It wasn't high tech, it was simple, low tech, and small in scale, but it was real. and it made a difference. And to me, that's what public health is all about. Thanks for listening.